How is MRD testing done?
Measurable residual disease or minimal residual disease, MRD, there are different methods in which it's tested. There are two common methods that you will see is next generation sequencing and next generation flow. The next generation sequencing method is the one that's FDA approved, and one of the companies that the one that's approved is the clonoSEQ method through the Adaptive Biotechnologies. The next gen sequencing method is looking at a baseline bone marrow sample which has myeloma cells in it and looking at a clone ID of those cancer cells, looking at the immunoglobulin rearrangement signature. So that signature can be unique as an ID to every patient, and that is the one that's followed over time to see if it's there, that sequence. So that clonal sequence is what's being followed. Whereas with next generation flow, this is a method using flow cytometry. Flow cytometry is a method of quantifying different cell types in the blood or any plasma. So what it does is it takes millions of cells from the bone marrow aspirate, or it could even be done from peripheral blood, but we don't do that for MRD testing. But when we take this bone marrow aspirate and we take all the cell fraction from it and run it through a flow cytometer, it's able to tell us the different cell types in that population. So what we are able to tell is how many of these are plasma cells and how many are abnormal plasma cells. It uses 10 to 12 colors, means 10 to 12 proteins on the surface of these cells to identify which category or which type they fit into. So this method requires, it's not an FDA approved method, but it requires the institute or the cancer center where you're getting your treatment to have this method, because it has to be a fresh sample. So as soon as the bone marrow is done, that sample needs to go to the lab and they need to run it through the flow cytometer. It cannot be done on a frozen sample. So when a fresh sample is used, they're able to quantify the abnormal plasma cells in it. The other differences is that the clonoSEQ method has a sensitivity of 1 in 1 million cells, so 1 in 10 raised to the power of 6. Whereas flow cytometry, given it's usually 10 color, is about 1 in 10 to the power of 5 or 1 in 100,000 cells. So there's a little bit of difference in the sensitivity of these two tests, though as flow cytometry gets better and we use more colors to detect these proteins, it can be as good as 1 in 1 million as well. So it just depends on where it's being tested and what method they're using there. Other differences is that, like I said, next generation sequencing requires a baseline sample and the clone ID, whereas next generation flow doesn't require a baseline sample. So if somebody never tested this at the baseline, you can still look for this in a follow-up sample. Often, if the next generation sequencing with clonoSEQ has not been done in the beginning, it is possible to do this with a frozen sample or a past sample if it's available by sending it to. So you could ask your doctor about that. Because it's a standardized test, it's much easier to do at all centers, whereas flow cytometry requires a center to have the expertise to do it. There's also another company, In Vivo Scribe, that also does a test similar to the clonoSEQ or next generation sequencing that some institutions use.
Can a baseline sample be obtained at relapse if the sample done at diagnosis is unavailable?
I think it can be done at a relapse. It basically needs to be done on a sample where there are enough myeloma cells to detect what the sequence is, and then it can be used when there's barely any myeloma detectable to look for MRD. But we cannot look for MRD if we don't know what it is when there is enough disease. So we have to have one sample with enough disease to find the clonal ID.
How accurate is MRD testing?
A test is as good as, the technique in which it's done and things like that. So if you think about next generation sequencing and next generation flow, they're both using a bone marrow biopsy sample. The bone marrow biopsy and aspirate. So if the bone marrow was done in a place where it was a little bit of a patchy distribution and we couldn't find any cells, it may look falsely negative compared to if another site has more disease. However, mostly bone marrows are not that patchy that you'd see really nothing in one place and a lot in another place. So overall, if it is negative, I think we can feel pretty confident that it is, because it's looking at 1 in a million cells, so it is looking at a lot of cells.
So what are the technologies that are currently approved by definitions for MRD testing? So per the International Myeloma Working Group criteria, a bone marrow test would be the platform. And the sensitivity level, 1 cell in 100,000 or 10 to the minus 5, that's how the definition is written. There are two types of technologies that are in the guideline. One is flow cytometry, and the other one is next generation sequencing. As long as these platforms have a sensitivity of 1 cell in 100,000, being able to rule that out, 1 myeloma cell in 100,000, you can declare MRD negativity. Technically, the next generation sequencing is about 10 times more sensitive than the flow cytometry. So the sequencing test can rule out 1 cell in a million. And the long-term progression-free survival is better if the patient is 10 to minus 6 negative versus 10 to minus 5 negative.
MRD can be measured in several ways with different sensitivities. We used to only measure it by flow cytometry, and that was a little bit difficult because different labs would do it differently. Now we have certain labs that are doing it very well and can detect as little as 1 in a million cells. Not all labs can do that, but the advantage is you can look at that at any bone marrow sample. At our institution, we're doing more is next generation sequencing. This uses the actual DNA clone that is specific to a patient's myeloma and identifies it in a diagnostic sample, and then uses that later as a comparison to see if any clones are still residual, for example, after a patient has undergone transplant. So this is really important for us because it's a way to get a very exact reading. Unfortunately, there are a certain percentage of patients where that indexed bone marrow sample is not available, and then we're not able to look at MRD by that way, but it also has a sensitivity of at least 1 in a million cells. So when we can get that test taken out or done, then we try to do that. If we can't do it, we do flow cytometry. No matter what, we try to have an informed discussion with our patients about what it means.
What are the pros and cons of next-generation sequencing versus next-generation flow?
So the two types of MRD testing we have are next generation sequencing, or NGS, and flow cytometry. They're different technologies. Next generation sequencing in a large part is done right now by a single company in a standardized way. And with flow cytometry, there are standardized flow cytometry methods, and there's also flow cytometry methods that are developed by individual institutions. They both have their pluses and minuses. In terms of sensitivity, currently means how low can we get? It looks like the NGS, or next generation sequencing, is a little bit more sensitive. Flow cytometry has its benefits in that you don't need former samples to identify that the sequence, and they can be done without those samples. The other thing that's good about flow cytometry is that it can potentially be done at individual institutions. The good thing about the NGS is that it's a much more standardized method.
Thanks for watching. By creating a HealthTree account, you can get exclusive access to the latest HealthTree University content, track your course progress, take quizzes, and bookmark lessons. Visit the links in the description below to get started.